All right, we are at 8 o'clock. Welcome to Grand Rounds today. Delighted to have Ryan Kipp, one of our own, our cardiology faculty, to provide Grand Rounds. And introducing Dr. Kipp will be Dr. Goldberger, Zach Goldberger in cardiology. So Zach, take it away.
Well, thanks. It's really a pleasure to introduce my colleague, Dr. Kipp. Dr. Kipp grew up in the Milwaukee area. He went to UW-Madison, getting a Bachelor of Science in Genetics, graduating with honors and highest distinction. While there, he was a member of the crew team for 4 years, resulting in being a team member of the national championship for 3 years and the 2-year national championship in the varsity 4. He actually received the UW-Remington Scholar Award for his accomplishments in athletics and academics. He went to medical school, internal medicine residency, cardiovascular disease fellowship, and EP fellowship at UW. And remarkably, after all this, he doesn't have a Wisconsin accent, really. Joined the faculty in 2013 as an assistant professor and served as director of EP at the Middleton VA before coming full-time to UW in 2022 as associate professor. His clinical area of expertise is the management and treatment of complex ventricular arrhythmias. Under his direction, the complex VT ablation program has grown exponentially in size and innovation, including developing the stereotactic beam radiation therapy program. He's an accomplished investigator, has authored over 20 refereed publications, most of which are first author and senior author, working with large national registries and mentoring numerous trainees. He has a particular interest in racial disparities in recipients of VT ablation. He also serves on several national committees and has delivered numerous talks at the scientific sessions for the ACC, AHA, and Heart Rhythm Society. Ryan's one of my personal heroes. One of the highlights of my week is when I'm able to join him in clinic on Tuesdays. Please join me in welcoming him as he walks us through ventricular tachycardia.
Thanks, Zach, for that really kind introduction. My name is Ryan Kipp. I'm an associate professor in electrophysiology. I have a particular clinical interest in ventricular tachyarrhythmias, both ventricular tachycardia and ventricular fibrillation. So what I want to talk about today is a comprehensive approach to management of ventricular tachycardia. Slides aren't advancing, let's see. There we go. I do have one disclosure, financial disclosure for this presentation. I received some research support from BioSense Webster to investigate disparities in atrial fibrillation management. I won't be discussing any specific products from BioSense Webster or referencing my research today. What I hope everybody will take away from this talk at the end, though, is that in a comprehensive approach to ventricular tachycardia management, it's really a collaborative approach. I hope to show throughout this talk that it requires an entire community of healthcare providers to best manage ventricular tachycardia. We're going to focus our talk today around a patient of mine. I saw him earlier this year in clinic. He's a 67-year-old male. He had a history of coronary disease and a myocardial infarction probably about 15 years ago. He actually had a proximal LAD, 100% occlusion, and had a late presentation, unfortunately, following symptom onset. He was subsequently revascularized, but as a result of the late presentation, he developed ischemic cardiomyopathy, as well as heart failure with reduced ejection fraction. He also has COPD. This is an outline of what we're going to talk about as we go through his care. First, we're going to talk about implantable cardioverter defibrillators, or ICDs, for primary prevention of sudden cardiac death. We're then going to move on to talking about medications for reducing the risk of recurrent VT, then discuss the psychological trauma of VT and ICDs, followed by ablation for treatment of VT, and then we're going to finish up by discussing advanced therapies, including stereotactic body radiation therapy. So back to our patient. He was started on maximal medical therapy with carvedilol, valsartan, and spironolactone. Despite those medications, his ejection fraction remained reduced at 30%. Due to an increased risk of sudden death, he was referred for ICD implantation in 2014. So why did he get an ICD? He hadn't had sudden death. Why was he at increased risk for it? Well, implantable cardioverter defibrillators, or ICDs, were originally developed and studied in patients who had survived sudden cardiac death. These were trials that were performed in the mid to late 90s. And what the investigators found was that patients who had survived sudden cardiac death, who are at high risk for having another episode, lived longer when they received an ICD. The problem with that approach, though, is that when somebody has sudden cardiac death as an outpatient, only about 10% of those patients will survive to hospital discharge. So there's a huge number of people who never even get the opportunity to benefit from an ICD. So the investigator subsequently asked, okay, what patient populations are at particular risk for having ventricular tachycardia or ventricular fibrillation? And can we get an ICD into the patient population before they have an episode? So there were a number of trials that were conducted in the late 90s and early 2000s looking at that exact question. One of those trials is presented here. This is the SCUD-HEF trial. In the SCUD-HEF trial, investigators randomized over 2,500 patients with ischemic and non-ischemic cardiomyopathy, a New York Heart Association functional class 2 to 3 symptoms, with an ejection fraction of 35% or less, despite maximal medical therapy. The patients were randomized to one of 3 arms in the trial. First, the first arm was ICD, which is shown in the green bar here. Patients were also randomized to an amiodarone arm and then a placebo arm of the trial. Over the 5 years follow-up, the patients who were randomized to receive an ICD had a significantly lower mortality rate compared to the patients randomized to placebo or amiodarone, with a hazard ratio of 0.77. As a result of the SCUD-HEF trial, as well as several other large landmark trials in electrophysiology, including the MADE-IT series, ICDs are now recommended as a class 1 indication for patients who have a persistently low ejection fraction of 35% or less, despite maximal medical therapy. When a patient's referred for an ICD, there's a couple of different types of devices they could receive. On the left is a transvenous ICD. This is the ICD that's been around for the longest period of time. With a transvenous ICD, you have the defibrillator or the battery system and computer system of the device located either in the upper left or the upper right portion of the chest. The device is attached to 1, 2, or 3 wires, which go through the subclavian vein, through the superior vena cava, and then into the right atrium. The defibrillator wire here then crosses the tricuspid valve and goes into the right ventricle. You can tell this is the defibrillator wire by this really thick portion at the end of the wire. This is the defibrillation coil. Using the information from the defibrillator wire, the computer system in the pulse generator in the chest is able to monitor the heart rate and heart rhythm. And if it detects that ventricular tachycardia may be occurring, it's going to run through a series of algorithms to decide, is the fast rhythm that it's seeing ventricular tachycardia, in which case it wants to deliver therapy, or is it supraventricular tachycardia, such as atrial fibrillation with RVR, in which case the device wants to withhold therapy. If it determines that ventricular tachycardia or ventricular fibrillation is occurring, the device will first rapidly pace the heart to try to get the arrhythmia to stop without delivering a defibrillation. But if the pacing does not stop the rhythm, the device will then deliver a shock, usually delivering energy from the coil up to the generator and then back again, with a very high success rate at terminating the arrhythmia. In the last 10 years, a new generation of ICDs has been developed, including the subcutaneous ICD. This ICD is a device that's located entirely outside of the heart and the vascular space. The reason for the need for this type of device is because when these leads in transvenous ICDs are implanted into the blood vessels, they're at very high risk for infection. They're also at high risk for failure. The blood vessels in the body's environment is really, really hard on the insulation and the metals in those wires. And so they can break or fail, which can result in device malfunction. Additionally, the wires, when they're in the central vasculature, can actually result in narrowing or complete occlusion of these central blood vessels, resulting in further complication and issues for the patient. So because of that, the subcutaneous ICD was developed. The subcutaneous ICD has a pulse generator that's located on the left side of the chest. It's located outside of the thoracic cavity. It's then attached to a wire that's tunneled in the subcutaneous tissue over the thoracic cavity to the midline, and then tunneled north, just on top of the sternum. These wires are sutured into position, and with this wire, the pulse generator can then monitor the heart rhythm. And if it determines that ventricular tachycardia is occurring, it'll deliver a defibrillation or a shock, again from the coil to the can and back again, to hopefully terminate the arrhythmia. In contrast to transvenous ICDs, subcutaneous ICDs cannot deliver that rapid pacing to terminate the rhythm without a shock. Additionally, the device cannot deliver pacing if the patient develops bradycardia. So back to our patient. He received a transvenous ICD in 2014. He actually did pretty darn well for the next 9 years. But in the spring of 2013, he was sitting on his back porch on one of those late spring days. It's getting warm, so he was enjoying the warm weather, He had a couple of drinks when he had syncope. That was unusual. He had not had syncope in the past, so he went to the emergency department. In the emergency department, his EKG was normal, blood work was normal. There was no signs of any trauma from the syncopal episode in which he had actually collapsed to the floor. So he was subsequently discharged home after receiving some IV fluids. So it was thought that he had overheated, probably got dehydrated, and passed out. Unfortunately, 2 hours later, he received 3 shocks from his ICD. He went back to the emergency department and was subsequently admitted to the outside hospital where an ICD interrogation was performed. The ICD interrogation identified 4 separate episodes of VT, each of which was treated with a shock from his device. So the first episode of VT, he actually didn't remember. He didn't remember receiving the shock because he was unconscious from the syncopal episode, most likely because he was little volume deplete. The reason he didn't pass out with the subsequent 3 episodes was because he had received IV fluid resuscitation. This is the information that was received from his defibrillator during the interrogation. This is the information. This is how the electric signals look in the heart from the tip of the ICD lead. This helps the heart. This helps the ICD determine the heart rate. You can see here that the defibrillator is recognizing each of those little spikes as a ventricular beat, saying V sense or ventricular sense. This time here is the milliseconds between each heartbeat, which tells you how fast the device thinks the heart rate's going. At 310 or 300 milliseconds, that's a heart rate around 190 or 195 beats a minute. This is a far field channel. This is what the heart rhythm looks like, kind of from a more superficial point of view, looking at the electrogram from the generator in the chest to the coil. And this helps the defibrillator determine if supraventricular tachycardia is occurring or if this is indeed ventricular tachycardia. By going through all of its algorithms, the device determined that this was indeed ventricular tachycardia. It charged the defibrillator, and then you can see here CE is charge enabled. It confirmed that the rhythm was still occurring and then delivered a 39.6 joule defibrillation, resulting in the rhythm to be terminated. So our patient, after admission, was started on an amiodarone drip. He had occasional non-sustained episodes of VT, but fortunately did not have any prolonged episodes and did not get another shock from his device. He then underwent a coronary angiogram, which showed no acute obstructive disease, and had a repeat echocardiogram, which confirmed an ejection fraction of 25%. So the next question in his care then is, well, what do we do right now to help prevent him from having another shock? So we have to look at which antiarrhythmic medications are possible. There's only a few antiarrhythmic medications that have been well studied in the management of ventricular tachycardia. This study, published in 2006, randomized patients who had received a shock from their ICD to one of 3 medications, either beta blocker alone, shown in this curve here, sotalol, shown in the solid curve, or amiodarone plus beta blocker, shown in this darker curve. The study followed patients out for 52 weeks after randomization and looked at the cumulative rate of ICD shock over the 52 weeks. The patients who were randomized to receive amiodarone had a significantly lower rate of subsequent ICD shock compared to patients randomized to receive sotalol and beta blocker. But what was equally impressive in this study was the annual rate of discontinuation of these medications. Over the 52 weeks of follow-up, 5% of people discontinued beta blocker, but 18% of people discontinued amiodarone and 23% of people discontinued sotalol. So while amiodarone and sotalol are quite effective at reducing the risk of subsequent shock from the ICD, they're not well-tolerated medications. They have a lot of adverse effects that make people not feel well, resulting in medication discontinuation, which does not bode well if we're trying to suppress ventricular tachycardia. We have a lot of particular concerns about the adverse effects of amiodarone, particularly if we have to use it in our younger patients. This is a meta-analysis that looked at the adverse effects of amiodarone from randomized trials that included this meta-analysis only included trials where the patients were on amiodarone a dose of less than 400 milligrams a day, where patients were followed then for more than a year. In this meta-analysis, there was a significantly higher rate of thyroid dysfunction, meaning hyper or hypothyroidism, neurologic issues, particularly neuropathy, skin issues, eye issues, as well as bradycardia in the patients randomized to amiodarone compared to placebo, with a significant trend towards an increased incidence of pulmonary fibrosis in patients randomized to amiodarone. Probably the most bothersome symptom that I see in my patients on amiodarone are skin issues, particularly in my younger patients. A lot of times they'll describe the feeling of their skin on fire or tingling and very painful when they're in the sun, really, really impacting their quality of life. They basically can't go outdoors throughout the summer. Some patients even have that feeling when they're driving in the car on a sunny day with the windows up because their skin is that sensitive to the sun. I had one patient with recurrent VF who said that he'd rather have another VF episode than continue taking amiodarone with that side effect, just to put in perspective how bad that side effect can actually be. By far the most feared complication from my perspective with amiodarone is the pulmonary fibrosis or interstitial lung disease that can develop. The reason why I worry so much about that is because it's a very slow developing problem. Oftentimes the symptoms from the pulmonary fibrosis will overlap with heart failure symptoms, meaning we're oftentimes late to recognize that it's occurring. And once it's occurred, it's really challenging to treat. We may be able to give people high dose steroids and get the problem to reverse, but it's hard to get it to fully go away. So some patients may be left with persistent long-term lung damage from amiodarone use. When the dose of amiodarone is increased to more than 400 milligrams a day, the rate of interstitial lung disease and pulmonary fibrosis can increase up to 5%, and thyroid dysfunction increases that greater than 20%. So our patient, after his evaluation in the hospital, he was transitioned to oral amiodarone with carvedilol prior to discharge, and then urgently referred down to UW-EP clinic, where I saw him about 2 weeks later. When I walked into the room and started talking to him, he said, "Doc, this device has gone off 3 times since discharge. What are we going to do about it?" And so that really took me aback. I knew that his referring clinic was closely watching his device for recurrent arrhythmias. They had notified us; they're a very reliable partner. And so we were like, "Whoa, what's going on? This is not good. We got to figure out we got to get this taken care of." So we went and got the computer to interrogate his ICD and pull the information to see what was going on. Fortunately, his ICD interrogation revealed no episodes of VT. So why did he think he's having VT? Well, unfortunately, he was starting to experience PTSD from what he had gone through. ICDs, they save lives. They're phenomenal devices, but there's this big dark side to the device in terms of the psychological trauma that they can cause. And it's not due to the device itself. A lot of times it's also due to the arrhythmia and the implications for having VT and ventricular tachycardia that weigh so heavily on our patients. In trials, there are a number of risk factors that have been identified for developing psychosocial distress following ICD implantation, specifically younger age, female gender, pre-existing psychiatric conditions, low social support, and then receiving 5 or more defibrillations over the course of their lifetime. That's appropriate or inappropriate defibrillations, meaning the device thought you were having a life-threatening rhythm, but you were not, but the device treated you as you were anyways and delivered a shock. So for example, if you had AFib with RVR, the device may misinterpret that as rapid ventricular tachycardia and subsequently inappropriately give you a defibrillation. In my personal clinic, I find usually around 2 or 3 shocks from the device results in patients start to develop some pretty significant PTSD and anxiety. By far, one of the most emblematic patients of PTSD was a patient that I saw a number of years ago. He had received 80 shocks from his ICD over a 2-hour period. The only reason his device stopped shocking him was because it ran out of power. So he was wheeled into the emergency department, still in ventricular tachycardia, but his device was dead. The battery was depleted, and he was in tears because he remembered each and every one of those shocks. We were fortunately able to control his ventricular tachycardia with medications and subsequently performed an ablation. And prior to discharge, we talked to him about the risk of recurrence, the fact that his VT could come back again. And so to help treat that rhythm, if it does recur, we'd want to replace his defibrillator. He couldn't go through with it. Despite the risk of recurrent VT and possibly dying, he said he couldn't stand the thought of a device in his body that could shock him anymore. And so we took out his device and he was discharged without an ICD at that point. He said that every time he closed his eyes, he was seeing lightning bolts hitting him and he was no longer sleeping. It was an incredibly traumatizing experience for him. In addition to PTSD, a lot of patients after just several defibrillations will have anxiety as well as depression. To put the rate of PTSD in patients with ICDs in perspective, After just 4 years of ICD implantation, the rate of PTSD is usually around 35 to 36%. That's similar to the rate of PTSD in patients who have survived sudden cardiac death, and far greater than the percentage of patients with PTSD that are seen in the primary care clinic, which is around 12%, and in the general population around 7 or 8%. So following reassurance that he had not received shocks, as well as discussing referral to health psychology, we then shifted our talk to what we could offer him to prevent another episode of VT occurring. He literally said, "Doc, I do not want to get another shock again. What can we do?" Fortunately, there are a number of recent clinical trials that have been published that help us address this exact question. This trial was published in Circulation in 2022. And what the investigators in this trial did is they took 47 patients who had both ischemic or non-ischemic cardiomyopathy and randomized those patients to receive, after they had an ICD shock. The patients were subsequently randomized to either receive an ablation or ongoing medical therapy with antiarrhythmic medications. The primary endpoint from this trial was death, hospitalization, or worsening heart failure, and the patients were followed up for 24 months after randomization. The patients who were randomized to an ablation following their ICD defibrillation had a significantly lower rate of the primary endpoint compared to patients randomized to ongoing medical therapy. The difference in curves was primarily driven by a significant reduction in all-cause death in patients who were randomized to receive ablation compared to the patients randomized to receive ongoing medical therapy with antiarrhythmic medications. Most pertinently for our patient, though, the patients in this trial who were randomized to receive an ablation had significantly fewer ICD shocks over the 24 months of follow-up at 9% versus 42% for patients randomized to ongoing medical therapy. A second trial was also published in Circulation in 2022, which looked at a slightly different patient population. In this study, 133 patients were with VT or inducible VT at the time of ICD implantation were randomized to receive either ablation or ongoing medical therapy. Over the 36 months of follow-up in this trial, the patients who were randomized to receive ablation also had a significant reduction in the rate of recurrent VT compared to the patients randomized to the control arm of the study, with 32% of patients in the ablation arm having a VT episode over 36 months of follow-up, compared to 51% of patients randomized to ongoing medical care. So based on these trials, I think it's fair to say that when patients have ventricular tachycardia, referral for ablation early in the disease process significantly reduces the risk of recurrent VT and may actually improve survival. So what do we do during a VT ablation? How is the procedure performed? Why does this reduce the risk of recurrent VT? To better understand that procedure, I think we have to take a step back and think about the pathophysiology of VT in patients who have structural heart disease. I like to start talking about VT pathophysiology with a gross specimen of the heart here. So this is the left ventricle, cut in cross section. This is the right ventricle here. This is the septum, anterior wall, inferior wall, and lateral wall of the heart. This patient had a large inferior lateral myocardial infarction. You can see that this is thinned out. This is scarred tissue. You can see the appearance difference here compared to the myocardium, the septum, and the anterior wall of the heart. Now, what I want people to do is focus on these edges here, where the scar and the myocardium come together. And you can see in this region that there is scar and myocardium interspersed amongst each other here. Now, when we look at this at the microscopic level, this is stages following a myocardial infarction. You have normal myocytes here. Following a myocardial infarction, you get cleft necrosis, some acute inflammation, granulation tissue about 2 to 3 weeks later, and then you get scar tissue forming 3 to 6 weeks after the infarction. And you can see here that you have myocytes interspersed with scar tissue. Now, when you get myocytes in close proximity and intertwined with scar tissue, the electrical properties of those myocytes change. They actually slow down the electrical conduction. It disrupts the speed of the electrical signal going between the myocytes. That results in a heterogeneous activation of the heart during any particular QRS complex. That heterogeneity sets up a situation where you can have a reentrant circuit develop. So this is a figure from a paper published by Bill Stevenson and Jack in 1997. He's one of the godfathers of VT ablation. It's a crude picture, but I like it because it really helps to exemplify why VT occurs. So these gray blobs here, this represents scar tissue. The white space between the gray blobs are those myocytes, those channels that we talked that we saw on the previous slide. Now, when the electrical signal enters these channels, it has slow conduction. So it's going to slowly propagate through the channel. Sometimes the electricity is going to take a little turn and go into this track here and then burn out. There's nowhere for the electricity to go. But sometimes the electricity is going to propagate through this channel, and it may actually find a way to go into the scar, propagate through a channel very slowly, and then exit out the scar at a remote location. Now, if this electrical conduction is slow enough, by the time the electrical signal reaches the exit site, the myocytes in this location may be repolarized and be capable of subsequent depolarization. If that occurs, the myocytes can be depolarized, allowing the electrical signal that is then propagated through the scar to exit out into the myocardium, loop around the scar to the entrance site where it re-enters the scar, creating a circuit. If this circuit gets set up, your body is no longer in control of its heart rate. This is what happens with reentrant ventricular tachycardia. The rate of the ventricular tachycardia is determined by the speed with which the electrical signal can propagate through this channel, as well as around this outer loop here, as well as the size of the loop. The bigger the loop, the slower the rate. But a lot of times when patients get these rhythms set up, their heart rates are going to go 150, 200, 250 beats a minute, which is clearly not a sustainable heart rate for patients with a cardiomyopathy. What I love about electrophysiology and ventricular tachycardia is that this exit site here can be identified by getting a 12-lead EKG from a patient in ventricular tachycardia. By using the 12-lead EKG, we can localize where on the myocardial scar this exit site's located, which can help us then plan our subsequent treatment patterns. So, using this information, let's take a look at what we do during an ablation. So this is our patient. He was brought to our electrophysiology lab and for a VT ablation. There is a lot going on this slide. So I'm going to walk everybody through what all this means in this kind of a stepwise fashion. So what we're looking at here is his left ventricle. The apex of the heart is here. We're looking at it kind of from the left shoulder. The apex of the heart's here. This is the septum. This is the lateral wall of the heart. This is the anterior lateral wall of the heart. And then this is the base. The aortic valve is here. The mitral annulus is right in this vicinity. Now, to create this map, we've placed wires into his heart, which allow us to create a geometric shell using a computer program called electroanatomic mapping system. To do that, we brought the patient to the electrophysiology lab and then put him off to sleep with general anesthesia. Because of his severely reduced ejection fraction, we actually had to place a pump called the peripheral left ventricular assist device, which sucks blood out of his heart and circulates it throughout the rest of his body. In patients who have severe cardiomyopathies and are at particular risk for having decompensation during our procedures, oftentimes we have to place a pump like that or full ECMO to help support the patient throughout the procedure. After the patient was hemodynamically stabilized, we passed those wires into his heart. Now, on the end of those wires, those wires that we passed into the heart is a little sensor that we can then use to sample the electrical voltage and at various points around the heart. Associated with that sensor is a computer chip, which allows us to localize each of those points in various spots around the heart in 3D space. We can then use that information to create a shell of the heart. Using the voltage sampled by the electrical signal, we get sampled by that catheter, by the end of that wire, we can actually determine if the tissue in that particular location is a scar tissue or healthy tissue, which is represented in a color-coded scheme here. If the tissue is scar, it's represented as red. So you can see that a vast majority of this heart is red because of his large anterolateral myocardial infarction so many years ago. Healthy tissue is represented as purple, as you can see up here. There's actually quite a bit of purple on the lateral wall of his heart and on the inferior wall of his heart that we cannot see. Now, each of those white bars corresponds to when that particular part of the heart is activated during a heartbeat. So as we are collecting that voltage information, the computer software was able to see when that particular spot of the heart was activated. We can then combine all the thousands of heartbeats. We actually sampled over 7,000 points in this heart. We combined all those thousands of heartbeats together to create a representation of a single activation of the heart during a single heartbeat, which is what is being displayed here. This bar graph, this little line on the side of the image here, this corresponds to where in the QRS we are, as well as where in the T wave we are, showing the activation sequence. So we're going to watch this and I'm going to walk you through this now. So here's the pacer spike and here's the QRS complex. So the electrical signal initially propagates up the septum as well as along the inferior wall. The electrical signal loops around to the lateral wall of the heart over here. And then you see that during the T wave, there's these electrical signals in this vicinity. There shouldn't be electrical signals going through the scar during the T wave. That's the repolarization phase of the heart. You shouldn't have ongoing depolarization occurring there. So let's watch it again. Right here, you see those electrical signals during the T wave, and then they kind of burn out in this location. Well, we're going to watch one more heartbeat. Watch right where my cursor is here. The electrical signals propagate up the septum. They then loop right in here and burn out. And then they loop around the outside of the scar, come through here, hang out there during the T wave, and then stop. So what you're seeing here is actually that channel that we showed on the previous slide. This patient had a channel going through here. So what we subsequently did is we paced this heart and we intentionally put it into ventricular tachycardia. When we put him into ventricular tachycardia, we were able to confirm that the ventricular tachycardia was utilizing this circuit here, going towards the septum, up around the heart, making a loop in this fashion. By burning in this location here, by burning through here, and then burning over here, as well as through here, we were subsequently able to eliminate his ventricular tachycardia. By burning the cells, we were able to kill the cells in those channels. And by eliminating those channels, we were able to then render his VT no longer inducible at the conclusion of our procedure. We were subsequently able to wean him off of the support device and get him extubated. And he's done incredibly well since the procedure with no episodes of recurrent ventricular tachycardia. Now, this is the endocardial surface of the heart. There are some disease processes which have a scar predominantly on the epicardial surface of the heart, such as in conditions like arrhythmogenic cardiomyopathy or non-ischemic cardiomyopathies. In those conditions, a lot of times the endocardial surface of the heart is entirely normal. It has normal voltage, but there's extensive scarring on the outside surface of the heart, meaning we have to get to the outside surface of the heart with our equipment to burn out there. There's a couple of different ways we can do that. One way is to do a percutaneous epicardial access and ablation. The way that we do it is we feed a small needle underneath the sternum towards the heart and then puncture the pericardial sac. We have to be careful not to go too far, because if you go a little too far, then you're going to also puncture the heart. Once we're in the pericardial space, we'll thread a needle, through that needle, we'll thread a wire that will go around the heart. And then over that wire, we can pass larger and larger IVs to allow us to get equipment into the outside space, into the epicardial space around the heart, to then create a map like we did on the endocardial surface. We cannot do a percutaneous approach if somebody's had previous open heart surgery or if they have adhesions from previous episodes of pericarditis, in which case we then have to work in conjunction with our colleagues in cardiac surgery to provide pericardial windows, either through a lateral thoracotomy or a subxiphoid approach, as is shown in these two figures on the right. These are figures taken from a paper published in Heart Rhythm in 2023. We don't do that procedure too often here, so I don't have any pictures of our procedures for that. When we get to the epicardial surface of the heart, the scar distribution is much different than the endocardial surface when patients have ischemic cardiomyopathy. Again, a lot of times epicardial scars are due to non-ischemic cardiomyopathy or arrhythmogenic cardiomyopathy. So the scars do not follow a vascular distribution, are much more splotchy, rendering the circuits really, really complex and challenging to control. This is a patient that we brought for VT ablation, for an epicardial VT ablation after he received 60 shocks from his ICD and outside facility. We're looking at the posterior wall of his heart. This is the apex down here. This is the base of the heart. And you can see the red star is interspersed with these healthy areas, and it doesn't follow any vascular distribution. This is just kind of haphazardly arranged scar around his heart due to the pathophysiology of his disease process. A lot of times we'll find that there's more extensive scarring close to the base of the heart here in patients with non-ischemic cardiomyopathy and arrhythmogenic cardiomyopathy. Now, when each of these little dots are ablation lesions that we created. So after we created our voltage map and our activation map, we put him into ventricular tachycardia, and his VT would actually propagate through this region, up this area here, and then it would actually kind of disappear. The circuit would disappear. It would probably go mid-myocardial, loop around, and then it'd show up again over here. So we're missing everything that was all the activation that happened in this region. But by burning through here, we're able to terminate his ventricular tachycardia. And following ablation, we can no longer reinduce the arrhythmia. Now, when we're on the outside surface of the heart, there's a couple of critical structures that we have to be aware of. The coronary arteries are epicardial structures, and he had large obtuse marginal arteries, large coronary arteries that went right through this vicinity. So we couldn't burn in the regions over here. In addition, he had a phrenic nerve. His phrenic nerve was right here. And so we had to be very careful not to extend our lesions too far apically to avoid damaging that structure. Now, when patients receive a number of defibrillations from their heart, again, those defibrillations they're incredibly painful. It feels like you're getting hit in the chest with a sledgehammer when the defibrillator goes off, or getting kicked in the chest by a donkey. When that occurs, obviously your adrenaline is going to go through the roof. It's a very traumatic experience for patients. When you get numerous shocks, with each subsequent shock, your adrenaline gets kicked up again and again and again. And adrenaline in those situations can be quite detrimental to trying to control ventricular tachycardia. It can actually result in the patients spiraling quite a bit out of control, with recurrent shocks being fueled purely by the adrenaline from the previous shock, in a situation called ventricular tachycardia storm. The treatment for that is to try to reduce the amount of adrenaline that the patient's experiencing as rapidly as possible, which can be done with intubation and deep sedation, as well as with use of non-selective beta blockers like propranolol. Sometimes, though, the adrenaline just does not decrease despite those interventions, in which case we need to think about percutaneous sympathetic control in order to stabilize the patient so we can get them to the operating room. There are a number of studies that have looked at ways to do this. There's no randomized trials, but looking at trials comparing the number of VT episodes before versus after interventions, we know that there's a number of ways that we can reduce the number of VT episodes that people are having when they have high sympathetic tone. One way is by placing a thoracic epidural catheter in the T1 to T2 or T2 to T3 space in conjunction with our anesthesia colleagues and pain management service. Through the epidural catheter, we can then infuse ropivacaine or bupivacaine, which can be titrated to response. We can also perform bilateral stellate ganglion blocks. Looking at the number of episodes of VT prior to thoracic epidural catheter placement, you can see that following thoracic epidural catheter placement, there's a significant reduction in VT episodes in each patient that was treated. When we find that percutaneous sympathetic control is effective at reducing VT, we'll oftentimes refer patients for surgical sympathectomy with our surgical colleagues in thoracic surgery. During a surgical sympathectomy, they'll remove the lower half to third of the stellate ganglion, as well as the T2 to T4 thoracic ganglion, either bilaterally or just on the left side if the patient is hemodynamically tenuous. In either situation, studies have shown that following surgical sympathectomy, there's a significant reduction in the number of VT episodes compared to the number of VT episodes that were occurring prior to the surgical sympathectomy. Again, there's no randomized trials looking at this, but empirically, based on the number of VT episodes that we see patients experience following this intervention, it's a great tool to have in our back pocket to help reduce VT in those acute situations. Now, up until a couple of years ago, this was really the limit of what we had to offer for treatment of ventricular tachycardia. But recently, another form of therapy has been investigated and is in the process of being developed, and that's stereotactic body radiation therapy. This is a procedure that's performed in conjunction with radiation oncology and medical physics. In this procedure, we deliver up to 25, we deliver 25 gray to a targeted location of the myocardium in a single dose. So we try to target the scar of the heart where those channels are located with 25 gray, with hopes of irradiating and disrupting the ventricular tachycardia circuit. There's no randomized trials that have been published yet looking at the efficacy of stereotactic body radiation therapy. The randomized trials are actually currently enrolling and ongoing, but we know from phase 1 and phase 2 clinical trials that patients who undergo SBRT therapy have a significant reduction, appear to have a significant reduction in the amount of VT that they experience. This is a paper that was published in 2019 out of Washington University. Again, that's the institution that really spearheaded the development of SBRT therapy for VT. And what they published here was their first 19 patients who were having ventricular tachycardia despite ablation, or patients who had contraindications to ablation. So some patients we cannot bring to the operating room either because they would not tolerate the procedure hemodynamically. If they have a big left ventricular thrombus, we can't bring the patients to the operating room. And sometimes we've tried to ablate them, and our catheters, our equipment that burn in the heart, just cannot reach the area where the VT is coming from. And in that situation, then we can try, but we may not be able to effectively eliminate the arrhythmia. And so in this phase 1 and phase 2 trial, they brought those patients for SBRT therapy, using the patients as their own control. So each line represents an individual patient. You can see the number of VT episodes pre-treatment on the left-hand side of this figure, compared to the number of episodes post-treatment on the right side of this figure. And in a vast majority of patients, there's a significant reduction in the number of VT episodes post-treatment compared to the number of episodes pre-treatment. But it's important to look at this patient right here. They were definitely having VT, quite a few episodes of VT and probably ICD shocks prior to SBRT therapy. But following SBRT therapy, the number of episodes actually went up. And I think this is important to keep in mind, not only with SBRT therapy, but also with catheter ablation, that we know that these treatments can reduce the amount of VT that people are having, but they're not a cure. And unfortunately, in some rare situations, it may not even slow down. It may, in fact, accelerate the arrhythmogenic process, requiring further therapy to better control the arrhythmia. Now, it was thought that delivering SBRT, delivering high dose radiation to the myocardial scar of the heart was going to form fibrosis in those critical channels, those critical isthmuses, and eliminate the ventricular tachycardia. But for that to occur, it generally will take 4 to 6 weeks to get the fibrosis to develop. And what the investigators at Washington University, as well as what we've seen at our own institution, as well as other institutions around the country, is that when patients get SBRT therapy, some patients will actually have a near immediate decrease or cessation of their ventricular tachycardia. Like literally day 1 post-treatment, they'll have 0 episodes going forward. So the initial mechanism of action, the initial benefit of SBRT therapy was really unknown, and I think continues to be unknown. The group at Washington University has done a lot of basic science research to shed some light on what in fact is going on when patients receive that much radiation to the heart. What they did in this study, this was published in Nature Communications in 2021, is they took mice and then gave them a myocardial infarction. And in some of the mice, they irradiated the myocardial infarction, similar to what you would do for SBRT therapy in patients. They then looked at the myocytes, and what they found was that in the hearts that had been infarcted and treated with radiation, there was a significant increase in the density of the sodium channels, as well as connexons, compared to the mice that had only received a myocardial infarction. Now, if you think back to your early medical school days, when you increase sodium channel density and connexon density, you're going to actually increase the conduction velocity. So it's thought that the antiarrhythmic effects of the radiation, at least acutely, may be due to increased conduction velocity through those channels, which is a little bit counterintuitive because we use medication. The antiarrhythmic medications used oftentimes will poison or slow down the conduction velocity through those channels. And so it appears, at least from this preliminary data, that the conduction velocity increases, and that seems to have an antiarrhythmic effect. at least in the mouse model. There's some evidence of this occurring in humans as well. This is one of the patients from Washington University, pre-SBRT therapy. He had a pretty wide left bundle branch block. His QRS duration was probably 160, 170 milliseconds. Following treatment with SBRT, his QRS complex actually narrowed, suggesting that he has an increase in conduction velocity, more homogeneous activation of the heart because of the radiation that he received. The group at Washington University also looked at an explanted heart from a patient who had received radiation. And what they showed was that in the portion of the heart that was exposed to radiation, there was a significant increase in sodium channels as well as connexons in that area, suggesting that the phenomenon that was seen in the mouse model does in fact occur in humans as well. At UW, we've been offering SBRT therapy now for about 3 years. During that time, we've treated 11 patients. This is the treatment for one of the patients that we brought to the radiation oncology treatment area and subsequently irradiated. This patient, he had mechanical aortic valve and non-ischemic cardiomyopathy. Despite antiarrhythmic medications, he continued to have a high burden of ventricular tachycardia. He was then brought to the electrophysiology lab where we tried to perform an ablation. We were able to induce VT, and I actually was able to map and localize his VT to the area immediately adjacent to and under his mechanical aortic valve. We then burned the arrhythmia in that location, and I could get the rhythm to stop, but after termination, I could always reinduce it, and then I'd burn some more, get that rhythm to stop. I could then reinduce a different rhythm, burn some more, get that rhythm to stop. We did that 5 or 6 times. At that point, it was pretty darn clear that we were not going to be able to make a long-term meaningful reduction in his ventricular tachycardia. And so following the ablation procedure, we closely monitored him, and he unfortunately continued to have increasing amounts of VT. At one point, he was having up to 30 episodes of VT a day. Fortunately, his device was able to recognize those episodes and treat it with rapid pacing rather than defibrillation. But with 30 episodes of VT occurring a day, he was developing heart failure. He actually went from New York Heart Association functional class 2 to 3, and then was teetering on New York Heart Association functional class 4 symptoms. He was short of breath with rest and could hardly walk around his living room. So we were eventually able to convince him to undergo SBRT therapy, which is being shown here. This is the beam rotating around his body, delivering the radiation to his heart, which is this pink structure here. And this is the target location here around the mechanical aortic valve. This green structure on the bottom is his stomach, which we are very careful to avoid irradiating due to the sensitivity of that organ. As the beam rotates around the patient, it's delivering varying doses of radiation, as determined by our radiation oncologists and medical physicists, to target 25 gray into the area around the mechanical valve where we knew his VT was coming from. This is an isochronal dose map of his radiation treatment. This is a sagittal view, so we're looking at the left shoulder going in towards the center of his chest here, from the apex of the heart towards the valve. The left ventricle's here, the right ventricle's here. This is the septum. You can see as we get close to the aortic valve, which is in this vicinity, we're getting up to 25 gray, which is represented by the red. The pink structure, the pink areas are getting up to 30 to 31 gray. We're now going to see an axial reconstruction of that treatment. Again, red is 25 gray, pink is up to 30, 31 gray. This is the valve right in there. And you can see that surrounding the valve and immediately underneath the aortic valve, we're getting 25 to 30 gray in that entire region. Now, again, as I mentioned earlier, he was having up to 30 episodes of VT a day. He was treated with his SBRT therapy here, and literally the next day his VT stopped. He did well for the first couple of weeks following his treatment, and then around week 4, we got a transmission that he actually had a couple episodes of VT that were treated by his device. We called him up, and he had actually stopped all of his medications for another medical procedure where he was told to be NPO. And he said, maybe don't do that. Unfortunately, he did that again around week 11. He said, okay, really just don't stop your medications. And as long as he takes his antiarrhythmic medications going forward, he's not had any more ventricular tachycardia episodes for over a year at this point. In addition to having no further episodes of VT, His functional status has significantly improved, and he's now walking a couple of miles a day. So this is a really, really big success story for our SBRT program. So to summarize what we've talked about, so first, ICDs improve survival in patients at increased risk of sudden cardiac death. However, ICD shocks are psychologically as well as physiologically traumatic. Antiarrhythmic medications such as sotalol and amiodarone can reduce the risk of recurrent VT, but those medications are poorly tolerated, and particularly in amiodarone's case, have a large number of adverse effects. Referral for VT ablation following the first ICD therapy significantly reduces the risk of recurrent ICD therapy compared to ongoing medical therapy. SBRT and other advanced therapies may be necessary for recurrent VT refractory to antiarrhythmic medications and ablations. But most importantly, I want everybody to take away from this talk that VT management is it's collaborative. It's across the institution. That's one of the things that I love about working at UW is the fact that we have amazing colleagues in all these different areas across the entire hospital to collaborate and provide our patients with ventricular tachycardia the best possible chance of getting the rhythm under control, improving the quality and duration of their lives. Thank you very much again for your attention this morning. I really appreciate the opportunity to speak with everybody today. Are there any questions?
Ryan, that was fantastic. Thanks so much. I'm going to just post some questions here to you from the chat. One question is, what barriers have you faced bridging SBRT to UW and supporting patients to enroll?
So that's a great question. Right now, we are only treating the sickest of the sick patients with SBRT. And I think that's a big issue. When we treat the sickest of the sick, they have so many other comorbid conditions that it makes it really, really challenging to get them through the procedure. The last couple of patients that we've treated, their VTs have actually been relatively well controlled, but they've subsequently, unfortunately, developed refractory heart failure. And so I think the biggest issue is not necessarily getting the patients here to UW. It's more the getting the patients here in a timely fashion, not referring them when they're really, really sick. In general, I think patients, providers hold on to their VT patients for far, far too long, and they're referred for ablation only when it's the last possible thing, when they've been shocked numerous times on medications, they've adjusted medications, they've increased the doses, and then they're like, okay, nothing else is working, let's do an ablation. That's not the right time to do it. When you delay ablation like that, the patient's hemodynamics are oftentimes worse, and then we're behind the ball in terms of getting them to SBRT therapy.
Yeah, I mean, it's really amazing. I guess I would imagine that the radiation oncologists are very excited about this procedure. This is something that we weren't doing many years ago.
Mm-hmm.
So
question.
I have a couple of questions.
Mm-hmm.
So most of the discussion seems to revolve around those with VTAC due to ischemic cardiomyopathy with scar tissue, et cetera. Is the same management plan applicable to those with like long QT syndrome or other causes where it's the physiology is different?
Yeah, so that's a great question. So the discussion, the treatment that we talked about today is for monomorphic ventricular tachycardia. Long QT syndrome and especially those inherited arrhythmias, a lot of times they'll have VF or polymorphic ventricular tachycardia. Those are generally not structural heart disease mediated. And so the treatment is typically not catheter based. There's some episodes of ventricular fibrillation that can be triggered by PVCs, in which case we can actually target the PVC with ablation, but usually that's kind of a unique situation. So everything that we talked about today is for patients with structural heart disease, either due to a myocardial infarction or due to a non-ischemic cardiomyopathy or a rheumatogenic cardiomyopathy.
But for those inherited arrhythmias, it's still an implantable defibrillator.
Oh, definitely, yeah.
Right? It's just
yes.
The ablation is not the appropriate next step.
Correct. Yeah. And the decision on the defibrillator really depends on which inherited arrhythmia is occurring and what subtype actually, but definitely not ablation in those situations.
So then do you recommend any patient with ischemic cardiomyopathy who receives an ICD for VTAC, should they all be referred for ablation, or only those who subsequently have had VTAC that's required shock be referred for ablation? When should they be evaluated?
Yeah, so when they have VT, that's the time to refer them. And that's the problem that we find, is that a lot of providers will hold on to those patients and then try medications, increase medications, and then they get shocked again and again. And the psychological trauma of those shocks compounds. And with each shock, the patients are generally getting sicker as they get older. It makes there are a lot of times their cardiomyopathy is worse, the hemodynamics are worse, and so then the ablation procedure becomes less effective. So we're really looking for the patients early after they get a shock. We don't really want to we can't really treat them before they get a shock with an ablation. There's some studies that have looked at that, but they haven't really panned out very well.
And I'm assuming, like, when you say providers, those patients are being managed by a primary cardiologist generally, right?
Correct. Yeah, cardiologist or electrophysiologist.
Well, aren't EP docs cardiologists?
Yes. Yeah. Yeah. Just a subspecialty. Yeah.
Yes. Yes. And then my other question, in your initial presentation, the patient that you talked about, who presented with syncope in the setting of having an ICD. I was surprised that ICD wasn't interrogated at the time of presentation. It would seem like that would be a natural part of the workup. How easy is it to get that interrogation, to get that data on presentation to the ER, et cetera? Is that a barrier? And your thoughts on that?
Yeah, so it is. It's increasingly easy to get now. A lot of the device companies now have devices in most of the high volume emergency departments that allow for rapid interrogation so that they can see what's going on. So the device is actually interrogated. It gets transmitted to the device company a lot of times, and they'll just say, hey, something happened, call cardiology, or nothing happened, don't worry about it. For some reason, I think he went to a rural emergency department the first time. He's from northeastern Wisconsin. They didn't have that capability. Even if an emergency department doesn't have that capability, you can always call the device company, and there's representatives covering almost the entire US. And so it may take them a little time to get to the emergency department and do the interrogation, but that information can be obtained.
Ryan, another question came in from the chat. It's actually a really intriguing one. Do you refer all patients to behavioral health when they get an ICD before they get shocked? Or do you sort of wait until they get shocked before referring them to other healthcare providers in that field?
So I refer them for, I wait after they get shocked. That's typical, unless there's some patients who, again, are really, really anxious about their device. After they receive it, they kind of pontificate, they chew it over, and they're like, oh boy, this is really freaking me out. If I pick that up during our clinic visits, then I'll refer them. Otherwise, it's something that I frequently will talk to with patients when I see them after they've received a shock. Is just say, like, hey, like, how are you sleeping? How are you coping with this? Yesterday I saw a patient whose family member witnessed them actually getting shocked, and the patient was fine, but the family member was not. So we actually talked about her getting referred to psychiatry as well, health psychology as well, because she was just beside herself. These are very traumatic situations for everybody involved.
Great. And the last question we have time for is what advances are there to better localize the embryonic circuit location to better help target the ablation or SBRT? I guess the question is, what technology are we developing to better localize this?
Yeah, so there's a lot of there's a lot of efforts that are being made to try to improve that. There's actually 126 lead EKG that is worn in a vest form that you can put on a patient, and when you induce ventricular tachycardia, it can help you localize where on the epicardial surface of the heart the ventricular tachycardia is coming from. There's a lot of limitations to doing that. One, you have to have the vest on the patient when they're in ventricular tachycardia. You have to run through a complex CT algorithm, and it's a very, very expensive device to use only a handful of times. There's some other technologies that are also in development to look at similar things. But I think that's really going to be a critical piece of information that we're missing, and something that we will hopefully be able to figure out in the next 5 to 10 years. We have data from the device, from the ICD, every time a patient goes into VT and gets shocked. And so my hope is that we can leverage that information, leverage the information from imaging technology, from our MRIs and CTs and their 12-lead EKGs to better figure out where in the scar it's coming from, so that we can either target our ablation efforts specifically to that location and better have a plan going into these ablation procedures that are long and complex, or even better, target them non-invasively with treatments such as SBRT therapy, and not even have to expose the patient to general anesthesia with ECMO for 4 hours or 6 hours on the table. If we can do all of this non-invasively, boy, that would be just phenomenal. These patients are so sick. It's really hard putting them through such a long, complex procedure.
All right, thanks a lot. That was really remarkable. I've learned a lot. I think everyone has.